Implementation science is moving from infancy into adulthood. In this video, we're going to explore how this relatively new field, which emerged with noble intentions, now stands at a critical juncture. Welcome to the Essential Implementation Podcast. I'm Dr. Christian Hudson. Let's get started. So implementation science emerged as a field in response to a persistent problem faced by healthcare systems in the 1990s. Despite significant advancements in medical research, many proven treatments weren't being effectively integrated into everyday clinical practice. This research to practice gap prompted researchers and clinicians to recognize the need for a systemic approach to address the barriers preventing evidence-based interventions from being adopted in healthcare settings. So as the field took shape, its mission became clear: to develop strategies that would help accelerate the uptake of research findings and improve patient outcomes. So the Implementation Science Journal was established in 2006, and early pioneers such as Martin Eccles, Brian Mittman, and many others laid the groundwork by developing theoretical frameworks to guide us. These frameworks aim to provide a structured approach for understanding the complex factors influencing the adoption of new practices in healthcare environments. And the field quickly gained momentum, attracting increasing attention from researchers, policymakers, healthcare organizations, and many others. And this growth was reflected in a surge of publications, funding opportunities, and dedicated research centers. Now, this expansion of implementation science really did underscore its potential to bridge the gap between research and practice, ultimately improving the quality and efficiency of healthcare delivery. And as implementation science continued to mature, we saw the development of many frameworks and different approaches. We now have implementation outcome measures so we can evaluate implementation. We have frameworks which help us identify what might be helping or hindering implementation, so we can diagnose settings, we can formulate implementation strategies, and we can try and reduce or remove barriers altogether. It's been great to see people get a better understanding that implementation is not just a one-time thing, it's a process, and to show people the stages that it needs to move through. We have lists of implementation strategies and hundreds of studies, if not thousands, that have tested these strategies to see how they relate to implementation outcomes. With all the theoretical models, theories, frameworks, studies, strategies, it's been great for researchers because we've been able to use all of this as a backdrop for additional implementation research studies. And we can use frameworks for things like designing our study, working out how we're going to collect data, what questions we'll ask, and how we're going to do the analysis. This proliferation of theoretical models has signaled real progress, but it's also foreshadowed some of the complexities that we now face and that have emerged as practitioners have attempted to apply these frameworks in real-world settings. The theoretical domains framework, normalization process theory, the consolidated framework for implementation research sounds pretty technical, right? Well, that's because they are. They're very difficult to learn and also difficult to teach. We can show these implementation frameworks to practitioners, and we have tried to teach them about them, but it simply hasn't translated into the positive outcomes we might want. It's the same with implementation strategies. Many of them remain inconclusive, and that's the ones that usually help, like education, training, facilitation, promoting adaptability, audit and feedback. They're all pretty hit and miss when it comes down to it. Although some healthcare systems perform exceptionally well, many will struggle to drive system change using implementation science. Translating research findings into practice remains a slow process, and there are still gaps in our understanding, particularly around sustainability, and implementation outcomes are seldom fully integrated into healthcare systems. As a result, all healthcare organizations still face significant challenges in effectively implementing implementation science-driven changes and advancing evidence-based practices. And what's more, the 170 plus theories, models, and frameworks now published within the field do not seem to have allowed the field to achieve its original aims, i.e. adoption, integration, sustainment, and ultimately impact. So what's happened? Well, as we'll see, implementation science, in its valiant effort to establish itself as a science, has missed a very important part of implementation. It now needs to decide how it will proceed. Remember, implementation science is only 2 decades old, and implementation scientists have been working to establish the field as a rigorous and legitimate science. It's been about survival and proving legitimacy these past 2 decades. Remember, the world of academia is driven by publications and peer-reviewed studies. It's not like the world of practice. It's a different kettle of fish. This has meant that most of those working in implementation science have predominantly focused on theory advancement, arguably at the expense of practical, context-sensitive implementation. Now, in order to maximize implementation science's potential going forward, Some of us are going to have to learn to balance theoretical exploration with practical strategies that address the needs of healthcare practitioners and stakeholders, ensuring both relevance and sustainability in real-world contexts. And yes, this might mean evolving past the notion that evidence is king and also getting past the idea of randomized controlled trials being the gold standard. Yes, RCTs, randomized controlled trials, are great for establishing causal inferences and demonstrating definitive truths, particularly in medical research, but their findings do not always translate seamlessly into real-world effectiveness when it comes to implementation. I could do a whole video on this, but RTTs work by as controlling for many contextual factors in the context we're running the trials in. Future contexts will be different and ever-changing, and there won't be a research team controlling for all these annoying contextual challenges in the next place. We may find something effective, we may find this way of implementing worked, but in the next place it could be completely different. So we need to extend and evolve the kind of knowledge we're generating. So this reliance on evidence and RCTs and more traditional methods to implementation research has resulted in knowledge that hasn't been very useful to practice. They want to know, how can I implement this? And we can't really tell them. We can only make recommendations based on the experiences of a previous context in the past. Recommendations like, well, ensure leadership engagement throughout, or try audit and feedback. But the question still remains, how can I do audit and feedback? Which leaders should I engage? When will I engage them? I barely have time to go to the bathroom as I'm always with patients. An example of this is there's over 140 RCTs on audit and feedback, and even if all of these showed a positive result, which they don't, it's very mixed. This type of knowledge just doesn't really help practice. It doesn't tell anyone how to implement. And despite this ongoing trend, many universities and researchers still remain solely focused on assembling an extensive evidence base without putting through enough energy into understanding how to actually transfer this evidence into practice. And even when we have something evidence-based, many researchers struggle to select relevant evidence, ask the right stakeholder questions, or use methodologies that yield practical, impactful results. This leads to studies with limited utility, redundant data, and poor applicability to frontline practice or policy making. Despite the vast volume of research published daily, only a small fraction influences clinical practice, leaving healthcare practitioners feeling disconnected from research efforts to address system or practice challenges. So maybe it's time for something new. I think most would probably agree we need to effectively integrate robust theoretical, evidential, and practical dimensions of implementation equally in our work. Perhaps it's time to get more creative in our implementation science methods. Traditional implementation science methods often rely on static approaches like surveys, interviews, and focus groups, which fail to capture the dynamic, cultural, and relational complexities of healthcare settings. This has hindered the field's ability to produce timely insights and address rapidly changing delivery challenges. Rapid ethnography focuses on fast, iterative data collection in local contexts. It emphasizes real-time, system-oriented analysis, capturing the relationships, behaviors, and workflows that define healthcare environments. Researchers can use mobile methods, accompanying practitioners, leveraging diverse data sources, and documenting observations in the moment. By harnessing immediacy and contextual relevance, rapid ethnography facilitates agile, actionable insights for improving healthcare delivery in complex, fast-paced environments. Rapid qualitative analysis is also useful in this regard. So are case studies. Now, whatever our research approaches are, our methodologies still need to yield meaningful, actionable results. Siloed approaches which fail to foster collaboration are no longer tenable. We know that traditional push models, where interventions are imposed, are less effective than pull models, which emphasize stakeholder engagement and participatory methods. Co-creation models and implementation ecosystems, where researchers and practitioners collaborate over time, show promise for achieving sustainable change, but require significant resources, trust, and relationship building. Our role is not just to collect data. Maybe it's also to work with practice to help them achieve their goals. And in doing so, we all learn something valuable and hopefully start getting more positive patient impact as things that work actually get implemented and sustained. Now, building trust, fostering engagement, and developing a shared vision will be essential for success. And a lot of our attention needs to go into this area. And check out my other video on this. Now, while there are no quick fixes, outreach and collaboration by implementation scientists can bridge gaps between theory, practice, and research adoption, despite financial and systemic challenges. Knowledge translation relationships between researchers and frontline health and social care providers will likely be vital. We also need to make sure teams on the ground have time to problem-solve implementation regularly. and in real time so that they can produce the very practical implementation knowledge we so desperately need in the field. This, of course, means we'll need theoretical models and frameworks which don't just focus on the micro level, so don't just look at teams and changing the behavior of teams, but also acknowledge the macro level, including community, policy, societal context, and our entire health systems. Of course, we can't expect implementation science on its own to deal with the wicked problem of implementation. It would be a mistake to do that and a mistake to reinvent the wheel. The solution is going to require an all-out collaborative effort from stakeholders across multiple fields. A combination of different methodologies can better address the complexities of healthcare implementation, and it's been refreshing to see calls for methodological pluralism. Examples of this are over the last few years, we've seen implementation science combined with improvement science and improvement practices leading to powerful outcomes. We've also seen the very welcome addition of complexity science and frameworks such as Trish Greenhalgh's NAS framework. A video will be made on that soon also. As a final point, training in implementation science also faces challenges. Most programs seem to be generic, failing to account for diverse training needs or emphasizing applied experience. We don't want a repeat of what's already happened, where we have the next generation just developing more and more theories and not really getting their hands dirty or involved much in practice. Embedding implementation researchers within healthcare teams and creating exchange programs could bridge gaps, fostering collaboration and providing mutual benefits. However, capacity building remains limited, with few institutions offering specialized implementation science training or mentorship opportunities. Education in implementation science must also shift to emphasize sustainability and de-implementation, cultivating a workforce equipped to bridge the gap between theory and practice. Working with the Yorkshire Humber Applied Research Collaboration, I've developed a training program which introduces participants to the basics of implementation science, but also teaches them its limitations, and then goes on with the use of case studies to show them how they can use research methods which not only connect more with practice, but are able to deal with complexity. I always keep classes deliberately small so the training can be tailored to each one of you. One-to-one time and group problem solving are paramount. So you can check out a link to the training in the description below. So just to conclude, implementation science has definitely established itself as a robust field, offering valuable frameworks and methodologies to help us understand implementation. This is no small feat, and we should celebrate that. However, the field's emphasis on theoretical rigor and evidence accumulation often limits practical application in real-world contexts. To bridge the persistent gap between research and practice, the field must embrace a more balanced approach, integrating theoretical exploration with actionable, context-sensitive strategies that address both micro-level and system-wide challenges. Future efforts really must prioritize adaptive, demand-driven methodologies that are rigorous, contextually relevant, and can keep up with the needs of practice. Thanks for watching.